This is Carol from STS. This is the version 6.22 upgrade webinar. We're going to walk through the operative section and hopefully get through the valve procedure section. On the call with me today from STS, I have Leanne Jones. For my QVO, we have Joe Brower. And then, of course, we have our lovely consultants. From congenital, we have Chastity. And from adult cardiac, we have Melinda. So again, we'll be starting with the operative section, and then we'll be taking questions at the end. Be sure to use the Q&A. I'm going to shut off the chat box now, so be sure to put your questions in the Q&A. This just helps us keep track of them. We can download them in an Excel spreadsheet if needed. So today is March 8th, starting on operative. We have calls on the dates listed here. Currently, we have a go live listed as July 1st that is under review with the task force. They have a call next week, and we'll have a decision if July 1st is still set or what the task force wants us to do with that. But we're still aiming for July 1st as of today. All right, and that's all I have on that. I'm going to hand it over to Chastity and to Melinda. We're going to start with the operative section. And Chastity, and we do have some significant changes within this section that you'll need to listen to for education purposes. But as always, we will have time before go live, once you get more into the form, to answer specific questions, and we'll have dedicated webinars just to Q&A prior to go live. So Chastity, I'm going to hand it over to you, and I'll scroll the screens for you and Melinda, okay. But just go ahead and get started and let me know if there's anything I could help with.
Okay, Carol, thank you. Sounds great. So we're starting with the operative section. And if you look to the left, or the screen that Carol has open on the far left, you see that already there are some yellow strikeouts, which means there are some fields that we have removed. So procedure location remains largely unchanged, as well as status. But when we get to op type, you will see that there are two op types that were removed for version 6.22. And this is op type interventional cardiology, as well as op type non-cardiac, non-thoracic procedure with cardiac anesthesia. So those two are now gone. We also have removed all of the NEERS data collection, both in the unit prior and post-surgery, as well as in the OR. From there, we have the incision type, and you see that those, operation type. So other than the two strikeouts, they otherwise remain the same. So at this point, the other thing I would like to point out on the left-sided screen is the endotracheal intubation performed. So this is going to actually be removed. And if you think about the analysis done with STS, STS does not use the intubation date and time. The definition for it is the date and time of intubation closest to the OR entry date and time. So sometimes that can be weeks in advance. Sometimes it's in the OR at the time the patient arrives to the OR. So you're going to see that we added some other options with that field, but not the intubation date and time. The analysis done is always the post-op ventilation time, mechanical ventilation time. And so that starts when the patient rolls out of the OR. And so it's a date and time that we currently spend a lot of time collecting on all of our patients that isn't being used in any analysis. And it's not horribly utilizable locally either. So hopefully this will be a welcomed change from everybody. So at this point, I'm going to turn it over to Melinda to start talking about the different way to handle some of the new adult fields.
Hi, everybody. Welcome. So you're going to see a lot of new changes here for the adult, the way you're going to collect these for the 18 and older population. So the first procedure type is a coronary artery bypass procedure, and that's fairly straightforward. Was a CABG performed? But then off to the side, you have to determine yes, planned, meaning this was a planned procedure. It was on the consent form. This is what they planned to do when they went into the OR. That's one option. The second option is yes, unplanned due to surgical complications. So I call this the oops category. Oops, I didn't mean to I didn't mean to cut that coronary artery, and now I've got to bypass it. It's a surgical complication. So they're in there doing something else, and they end up having to do a cabbage because of a surgical complication. And then we have another category, yes, unplanned due to unsuspected disease or anatomy. So let's say they're in there doing a valve, and then for some reason they determine that there's some anatomy or even disease that they did not know pre-op, and now they have to perform a cabbage too. So that would be your choice in that particular situation. And then, of course, we have a no. And the next category, which looks very similar to the one we just talked about, is the aorta procedure performed. So these are procedures on the aorta. So that would be the root, the arch, the ascending, the descending, thoracic descending. We don't actually go all the way down. We isolated descending are not captured. So pretty much if it's a thoracic descending and up, you're going to capture it as an aorta procedure. And the same categories. Yes, this was planned. We meant to do that. We were going in the OR to do an aorta procedure. Yes, this was unplanned due to a surgical complication. Oh no, I dissected the aorta. Now I've got to fix it. Or yes, this is unplanned due to unsuspected disease or anatomy. They go in there to do an AVR, but then they decide there's an aneurysm in the aorta and they're going to fix that too. So it's new disease. They didn't realize that. And then we have the third category up here is valve procedure. So yes or no. And the reason this one slightly looks a little different with two choices, because you'll see further down, we have it broken down into the different types of valves with the same 4 choices. So if you say yes to valve procedure, the next step is they want to know, was a valve explanted? So, and for the purposes, that means that the patient had a prior valve that you're explanting. It does not mean they got in there like they're doing an AVR and they put a valve in, but then they decide it's too small, so they take it out and they put another one in. That's not a valve explant. An explant is a valve that was previously put in, and we're going to take that out. So you answer that question, then you move down through each one of your valves. So you've got your aortic, neo-aortic truncal valve, and they want to know the same things. Was it a planned procedure? Or was it unplanned due to a complication, or unplanned due to unsuspected disease, or no, I didn't do one? If you say yes, any of these yeses, then there's a child field that comes over and it says, was a procedure performed on the aorta, yes or no? Now, I know this is a little awkward because you've got an aorta procedure at the top, you've got valve procedure at the top, and yeah, we're asking it again. But if you're actually entering a aortic valve and an aorta procedure, a combined procedure, you have to answer 1765, 1770, 1780, and 1785 to get all of the fields and the appropriate sections to open up. And that will be laid out pretty clear in the training manual. It's just a little cumbersome at first, and you just kind of have to get used to it. But once you get used to it, it's fairly easy. The next section we go into is a mitral valve. So did you do a mitral valve procedure or your AV systemic AV valve procedure? And the same 4 questions. Was it planned? Was it unplanned due to a complication? Was it unplanned due to unsuspected disease? Or no, I didn't do a mitral valve. And then the same for the tricuspid and the same for the pulmonic. The same questions. Once we get through all of that section, we move into another section called other cardiac procedures except AFib. Okay, so these are, like, for example, subaortic stenosis resection, or a tumor, an LV tumor removal, or an RV repair, or aneurysm, LV aneurysm repair, for example. Those are just a few examples that come to mind. These are procedures not AFib procedures. We have a separate category for your AFib procedures. So, and the same questions. Was this planned? Yes, I plan to go in there and do an LV aneurysm repair. Or again, was it unplanned due to complication? I accidentally perforated the right ventricle. Now I've got to fix it. So that's a surgical complication. So unplanned to that. Or yes, unplanned to unsuspected disease or anatomy. They get in there and they see something that they did not know pre-op, a new finding, and it wasn't a surgical complication, and they have to fix it. Or no, we didn't do any other cardiac procedures. The next category is other non-cardiac procedure, and it's just a yes or no. So examples here would be like a carotid. So they're going to do a cabbage with a carotid endarterectomy at the same time. Or, or they are going to do some sort of vascular procedure or a thoracic procedure or some other planned or even non-planned procedure that's non-cardiac in nature. The last category for the adult patients 18 and under is the AFib procedures. Now these are your MACE procedures, your pulmonary vein isolation, your PVI procedures. These are your left atrial appendage amputations or clipping procedures. So you would just answer yes or no if they did an AFib procedure during the operation. Chastity, do you want to comment on the the congenital cases there?
Yes. So then
I'm sorry, this is
yes.
Carol. Can I just step in? I'm sorry. Two things. I accidentally locked the webinar when I went to turn off the doorbell. So I apologize if you were trying to get in and it said the webinar was locked. I unclicked that button. Sorry about that. The other thing I just want to point out is the parent relationship to these adult fields. So we're looking, these will only open if operation type contains CPB cardiovascular or no CPB cardiovascular, and the patient is equal to or greater than 18. This age will be we'll be looking at the age days field to come up with this this parent to the field. So two things have to happen: the CPB or no CPB cardiovascular, and then the patient has to be equal to or greater than 18. Otherwise, you will not see these fields in purple for the congenital population. Okay.
Perfect. Thank you, Carol, for adding that. So if your op type is CPB cardiovascular and no CPB cardiovascular, and you are younger or equal to 18, then our usual questions that we're used to will we answer these anyway, but a coronary artery bypass procedure performed, yes or no, and then a valve operation, yes or no. And then of course, these have moved into a different section. And so our usual answers are there, although we have changed kind of the naming or nomenclature of the valves. So we'll review that section when we get to it. But then we move on to our OR entry date and time and skin incision, or I'm sorry, I think these are just times because we already have the dates. And so you enter those as usual. What is new then, because remember I said that we got rid of intubation date and time, but what we have now is a field called endotracheal intubation performed, yes or no. So was the patient mechanically ventilated essentially for this procedure? And you're answering now yes prior to entering the OR for this procedure. So in other words, your patient had already previously been ventilated, so up perhaps in the ICU or elsewhere, or that they were intubated in the OR for this procedure. So the patients that come in, whether from home or up in your unit, and get intubated, that they're in the OR by anesthesia, or no, that there wasn't endotracheal intubation performed. So in other words, maybe the patient just had conscious sedation and didn't require an airway, or maybe just had an LMA, so didn't have invasive mechanical support. And then we have our usual extubation dates and times. Was the patient extubated in the OR? And then if the patient was not extubated in the OR, there's this total initial post-op event hours. And this will be a calculated field. And it's going to use your initial extubation date and time, I believe, to calculate this field. Am I correct on that, Carol? Because it's taking OR exit to the initial extubation date and time. That's correct. And so then this is a new calculated field for us. And then was the patient reintubated for any reason after the initial post-op extubation? And that's a yes or no. So again, what you see removed are some of the, the final date and time of extubation and things, since we know that a lot of that was not very helpful. And I don't think it really gave us, lended anything to the analysis or added to the analysis. So we think this will be a more succinct way to collect that data. Then we move on to incision types. So the incision types have not changed. But I think the reason it looks like new fields is that it's now a multi-select field instead of everything being yes, no, yes, no. Did you do a sternotomy? Yes or no. And going by each type, it's now multi-select. So you select the incision types that the patient had. And of course, if it was a partial sternotomy, you still pick if it's upper or lower. If the op type was thoracotomy, then it's left, right. We also added bilateral since that was not there before. And then was the chest left open after the surgical procedure with a planned delayed sternal closure? Yes or no? So this is taking care of, I know many programs struggled with sternum left open planned and sternum left open unplanned in the complications. And so the point is here, we're just answering yes or no. Was the sternum left open when the patient left the OR, with plans later to go back and do a delayed sternal closure? So that should help. I think my own surgeons included at a point in time really struggled with, but leaving the sternum open was the right thing to do. And so I think that this takes away it was planned or unplanned and any feelings about that. So then otherwise, the rest of the section is largely unchanged, with time of skin closure, exiting the OR, procedure extended through midnight, surgeon NPI, all of that remains the same. And then we start getting into some perfusion data. So we do have our number of prior cardiac operations and prior CPB cardiac operations. We will make sure that those definitions are clarified in the training manual. We've heard you, we know it's a problem. And then we have the cross clamp time for no CPB cases as well. And then we move down into perfusion strategy for older than 18. So I'm going to turn it over to Melinda to take on this section.
Thanks, Chastity.
I'm sorry, before we go into
yes, please.
perfusion, can we just clarify a couple of things that were said up above regarding, there's 3 questions in the chat box. Or in the Q&A. I'm just going to take these and then we're going to move on, but just so we don't miss them. Reintubation for any reason, not just cardiorespiratory failure. Is that correct?
Oh, yes. Should remain the same in the definition, that they were reintubated for any reason after the initial post-op extubation. Yes.
And then we did have, thank you.
Oh, no, I would say in the complications, we have the unplanned reintubation for respiratory failure.
Okay, and then the next couple questions are related to the incision type, the video-assisted thoracoscopy, and then collecting the location. And we had some discussion about this, and Chastity, I'll let you explain why we removed the location just for thoracotomies. We are still collecting the locations for video-assisted thoracoscopy.
Oh, I see. I apologize. I should put my glasses on so I can see the small font, right? Carol, I'm not sure why we said to get rid of the thoracotomy location.
I don't think it really,
just keep that. I don't think it mattered. Like there wasn't.
I don't think it mattered to collect that information, just that a thoracotomy was performed, but the VATS was a little bit more looking at the procedure and how the procedure was performed, what approach they were taking for the VATS. So that was a surgical decision to remove the location on the thoracotomy, but still collected on the VATS.
Correct. Yes.
Planned delayed sternal closure. It still includes the word planned. Will that be better defined in the training manual?
Well, I think anytime we leave a sternum open, we plan to close it. And so I think that's the point of the language in the question, is that we plan to go back and close that sternum. And so I don't think otherwise you would leave a sternum open. Somebody can't walk around that way. And so that's the use of the word planned, which I know is a difficult term to throw into the data collection form or in the training manual. And of course, we'll provide as much clarification for this as possible. But in other words, it's not that the chest was left open, planned or not. It's that the chest was left open with plans that someone is going to go back and later close that chest. So in other words, you're answering, was the chest left open when the patient left the OR?
Right.
Will the planned sternum go away then in the complications? Yes, I believe we removed that from the complications because we just want to know yes or no, was the sternum left open when the patient left the operative setting?
Thank you. Okay, moving on. Thanks, Chastity.
Sure. Thank you.
Handing it to Melinda.
So now we're
Like
going to
volleyball, Melinda.
so now we're going to move into for the adult, like the older than 18-year-old patients, are going to move into perfusion strategy. So the first choice is left heart bypass, and left heart bypass is utilized basically for descending aorta procedures. So it's not that common, but if you're doing a lot of distal descending aorta procedures, you might see left heart bypass being done. It's usually very clearly documented in the op note or even on the perfusion record. So it's a specific type of bypass. And then the next choice is combination. And basically we want to know, was this combination planned or unplanned? So what do we mean by this? So when we think of coronary bypass, and we're thinking about a full bypass, you have aortic venous cannulation, you're doing full bypass via the heart-lung machine. At times, there are procedures that are started off pump, but for some reason, perhaps the patient becomes unstable or there's inadequate exposure that they have to go on full bypass. So if you start off pump and you go on pump and it was unplanned for a reason that I just mentioned, hemodynamic instability or exposure issues, then that would be an unplanned combination. However, if the plan from the beginning, we're going to start off pump, we're going to do this off pump, and then we're going to do this on pump. If that was a planned procedure, then you're going to choose planned for the bypass. And then we ask about full bypass. So if you didn't do left heart, you didn't do a combination, you just did full, this is probably the most common choice. Just put the patient on, they're on full bypass. The next thing we want to know is the arterial cannulation insertion site. Now, this is the site where the arterial cannula is inserted. And Chastity told me that this is kind of new for you guys. I'm not used to looking at things with this detail level. So we will provide training on this, but basically we have an aortic choice, and that's very common. You have your axillary cannulation site, your femoral, your innominate, or other arterial cannulation site. Like I said, the most common is probably aortic. At times, femoral will be done for redo operations and things like that. Axillary for aorta procedures. So, and you can select all that apply. So you can have more than one arterial cannulation site. And it just takes a little time to get used to reading the op note or working with your physicians to better address the cannulation sites if they don't currently do that in their op notes. The next cannulation site that we are asking for is the venous cannulation insertion site. We have several choices, whether it be femoral vein or pulmonary vein or your jugular vein, your SVC, your superior vena cava, or your inferior vena cava, your IVC, your right atrium, your left atrium, or other. Most commonly, you're going to see right atrium. That's your most common venous cannulation insertion site, unless the surgeon is doing bicable. If he documents this as bicable, then you're going to choose the SVC and the IVC because those are the insertion sites for bicable. In the adult, for those of you, because I see some names here, they're on do the adult too. For those of you in the adult, we don't have the IVC choice, so we're adding it here. We need to add it to adult with the next upgrade. So for bicable, it would be SVC and IVC.
Melinda, I have a quick question here. Often, and just so we don't get past this, oftentimes surgeons will state that typical cannulation was performed.
Right.
How would you, do you want to address how sites should handle that dictation when you don't
Well,
specifically say the
that
site?
issue, because I see that a lot, standard fashion or typical method or whatever. In my mind, I probably know what that means, but you really need to clarify with your surgeon what that means, and perhaps even have you can even develop a little protocol. So my standard method of cannulation is aorta and right atrium, and if I document that, that's what you choose, and just have him sign off on that and keep that in the event of an audit, because a lot of surgeons do that. And that is the most typical. That's really the standard fashion is aorta and right atrium. If they do other things, they usually address what they've done. So work with your physicians to develop some sort of protocol for that if he documents that way, or perhaps work with him to document better. Whichever's easier for your site.
Check both. This is a good point, Melinda. And I think that right now, when I looked at this data collection form, I started looking at my surgeon notes and perfusion records to kind of see how this is new information that we need to collect. And I'm not used to looking in the op note for this information. And so I was already getting a feel for each of my surgeons, how they may or may not currently dictate this, and how I may want to see them dictate this to make it easier. And if there are ways that my surgeons use templates, and I can usually convince them to add anything to their templates. So especially if I want something documented by them, I say, please put this in your template, and then it gets added in each of the surgeons' templates, and they know to include that specific piece of information. So this will be the time where you can start working with your surgical teams to start getting some of that information in your op notes. So when we go live, you're not behind the 8 ball trying to figure out how to get this information. So perhaps start already reading your op notes and getting a flavor for them for this information, and start working with your surgical teams now.
Yeah, that's a great point.
Yeah.
So then back to everybody fields, we then have CPB blood prime, yes or no, which is not any different for us. However, we removed the amounts. So no longer do we need to collect the amount of the packed red cells and FFPs and whole blood that we're giving as a part of the CPB blood prime. Then the CPB time and minutes, cross clamp time, and circle rest time remains unchanged. We still have induced fibrillation, yes or no, and then the time and minutes associated with that. When we get to core temp measured, we have now changed this field, which I think will make it a little bit easier. Was a core temp measured, yes or no? What was the lowest temp, and what was the temperature source? So with this temperature source, no longer is it a yes, no to each one of these sources where we can obtain a patient's temperature. We're selecting one. And I'm going to have Melinda, this comes over from the adults. It's how they collect their temperature in the OR. So I'm going to have Melinda speak to this a little bit as to if your site perhaps, maybe your perfusion team documents a temperature in 2 different places. Which one do I use?
Well, we have this pretty clearly laid out in the adult training manual. So temperatures, are typically either documented on the perfusion record or the anesthesia record. So when coding the temperatures, what we ask the sites to do is to use the same source consistently for all their cases. So let's say, for example, I'm going to use the bladder. I'm going to use the bladder each time and that's the temperature I'm going to look at, and that's the temperature I'm going to get the lowest temperature from. So it's important for you to identify a priority source and a secondary source. So I'm going to always use the bladder, but if I don't have a bladder, I'm going to use the CBP venous return. We also have it fairly laid out that the core temperature is most accurately measured by the esophageal, the nasopharyngeal, the bladder, the rectal, or the oxygenator outlet, or the JB methods. So we encourage sites to choose one of those methods as their method of choice. The other methods, such as esophageal and CPV venous return, aren't as accurate. So we discourage that being your priority source, but if that's all you have, feel free to use that. But it is important that you pick one site, use it consistently, record the lowest temperature from that site, and then also have a backup site in case that particular site is not documented. Hopefully that clears that up and it'll make it a little easier for you.
Yes, absolutely. And now we're only recording one lowest temperature, so not the lowest temperature for each site. So it does clean up this a little bit and kind of decrease the data burden for these cases. So then we still have the question, cerebral perfusion utilized, yes or no? And you'll see that we removed some of the questions related to cerebral perfusion, and we're going to collect cerebral perfusion time and minutes, which is not a change, and then the cerebral perfusion type, whether it's antegrade, retrograde, or both anti and retrograde. And we no longer will then collect the other fields as related to cerebral perfusion. So we had periods, flow rate, temperature, and the cannulation site. All of that has gone away. I don't know about you. This makes me incredibly happy because my perfusionists do not routinely document this, and I have to chase them down sometimes to figure this information out. You think they'd get tired of me and just start documenting it on their own. So then we have cardioplegia delivery that remains unchanged with type and then also the solution. And then we have changed the labs a little bit in this section. So we're now going to collect the first hematocrit measured when after the patient enters the OR, and then the lowest hematocrit measured while the patient is on cardiopulmonary bypass. And then unchanged is the hematocrit post bypass. So gone are the previously recorded hematocrits that we collected first after initiating CPB and last measured during CPB. So those are gone and have been replaced then by the two new fields, and we left the hematocrit post CPB. Then was ultrafiltration performed, yes or no? And we have the same selections here as to when your ultrafiltration was performed. And then for anticoagulant used, the change here, it's not a new field. As you see, we haven't added anything to this, but we made it a multi-select field. So no longer do you have the burden of answering yes, no, yes, no, yes, no to each of the anticoagulants. Instead, you just select the boxes, select the ones that you did use. So then blood and blood-related products. This section has moved around a bit and has been simplified. So was there an autologous transfusion? Yes or no? Was there a transfusion of non-autologous blood products during or after your operative procedure? And then were they initiated before leaving the OR, within 24 hours, or post 24 hours? And so these are now all, as you see, yes or no procedures. And then we move into the antifibrinolytics used. Again, this becomes a multi-select field instead of yes, no to each of those individually. And then the procoagulant use as well. We've added a factor 7A, 7 fact. I think it's just probably a new factor that has come on the market since the last version. So what you'll see largely is that the blood fields and the amounts have gone away, unless you are an anesthesia participating program, in which case then these have been just moved to a different section, and we'll get to those when we cover the anesthesia section in more detail. And with that, I think we're done with our content for today, and I see that our box is filling up with more questions. Or unless you want to go through, Carol, do you think you want to go through the cabbage?
I think that, how about we answer these questions now, and then if we have time, we can just talk about the cabbage procedures. It's cabbage isn't a big lift, but we can go through the questions if that's okay.
Yes.
Angie had a suggestion or a statement about removing planned delayed sternal closure because it's confusing and doesn't seem to add anything.
This is
So-
Melinda. Maybe I can comment on that a little bit because we've been collecting this field for quite some time in the adult database. I think that it's important to know if the patient leaves the OR after the index procedure with an open chest. And of course, with that being said, there's always a plan, as Chastity said earlier, to close that chest. You can't just walk around with an open chest. So it's important to know if they're leaving the OR from index procedure. Okay, so this is after the index procedure. It only applies to the index procedure.
I
Unless,
think it's a little different for us, Melinda.
even though it's got our definition.
I think we'll answer this after because you guys only put in one procedure.
Oh, that's true.
We
That's
put
true.
in
So after
any
every
procedures that
procedure for
occur. So
you, I
we'll
guess.
answer this for every case. Did the patient leave the OR with their sternum?
Right. Okay.
Sorry.
So I think it's important to know that. I mean, and then we don't count these as re-ops and complications or anything because it's planned. It's a planned closure.
Mhm.
So it doesn't count as a complication.
Yeah, I think, Angie, what you're just saying is you just want that verbiage removed. I don't know at this point if we can make that change or not, Carol, but I mean, the point is, you're really just answering the question, did the patient leave the OR with their sternum open? Yes or no?
Yeah, and we'll clarify in the training
Mhm.
manual what that means. Next question, and a couple this one's from Janet, and then also Krista says, make sure that we define the right and left as systemic or pulmonary, not by anatomic. And what we were talking about when these questions came in was the cannulation sites. And I know it says it's confusing on the kiddos, but these fields will be collected on adults. But I still think we should clarify that further. Right atrium, left atrium, and versus the systemic versus pulmonic verbiage.
That's a great suggestion, absolutely, because our kids don't follow the rules.
Mhm. But I think even some adults don't, right?
Right, because our kids turn into adults. And so, yes, then they're not following the rules.
Yeah. Wouldn't the perfusion temp come from the perfusion report because the anesthesia section also asks for the lowest temp?
Not necessarily. Again, we've asked you to pick a site, a consistent site, and to try to pick a site that is a core temperature or more accurate core temperature. Like I said, CPB venous return is not very accurate as far as core temperature goes. It is a choice there, though. If you're using your oxygenator arterial outflow from your CBP, that's a very accurate method. The difference between this temperature and the temperature in the anesthesia section is that
Let me
the
pull that up.
temperature,
Let me show that field. So this is core temp measured, and then the temperature source and the lowest temperature. This is lowest core temperature. So let's go down to the anesthesia section. Hold on one second. I don't want to have to do all that scrolling. It might cause seizures. So this is the anesthesia, and we have the lowest recorded intra-op temperature. And
and this is your definition,
and not
Chastity.
necessarily
So
a
I don't know. I mean, we differentiate this in adult. In adult, we want the temperature from the anesthesia record.
This is not a core temperature, right? This could be axillary skin, tympanic. So this is just the lowest recorded intraoperative temperature.
Yeah, and we specified in adult that temperature has to come from the anesthesia record. It's the temperature that the anesthesia is using to dictate how they plan their care, their cooling and rewarming, how they do all that stuff. So we clarify it very differently than this temperature. And I don't know what you do in congenital, Chastity.
Well, so I think that this is going to be something, thank you all for your questions related to this, but this is going to be something that we're going to have to think about very carefully in our definition, since we're using this new verbiage for core temperature coming over for adults. We've not done that before because we could just select all sites used and put in the lowest temperature for each of those temperature sources. And then anesthesia had its own temperature and temperature definition. I think many of you are right that a lot of us have gone through this data collection where we record perfusion temps, which usually are core temps, from our perfusion records. And then in the anesthesia section, we either use the anesthesia temperatures, or again, we can also just repeat the perfusion temperature there. So I think that this will be something that we need to go back to our anesthesia clinical champions, as well as Dr. Subramanian, to see how we want to do this, and if we're going to, specify one comes from one record, one comes from another, because we can absolutely do that. We've not made that differentiation to this point in time.
Mm-hmm. And I think what we're asking I think that's good information. I just to ease any concern, we will be providing very clear definitions on these, on both of those fields. And for adult cardiac, you can expect that this definition will be pulled over for the lowest core temperature, and we'll provide information about your sources, right? Like Melinda said, esophageal, CPP, venous, return bladder, nasal, pharyngeal, etc.
And then I see, Liz, your question, if we're collecting the lowest temp, how do we choose the preferred source if we have multiple temp sources? So you're right, my anesthesiologist will record it in 2 different sources. Then my perfusionist, they always document 2 different sources. And so now I have to decide what's going to be my most consistent core temp for this section. And so personally, I'm likely to choose a rectal temp because they do that most consistently. So that's probably going to be my gold standard. And then secondarily, I trying to remember what, maybe it's a bladder temp, is their second source. And so I think that each of us is going to have to, kind of figure out what our core temp is and what that gold standard is. And that may be just a difference in the art of being a perfusionist at your facility versus another facility. There is often a discrepancy between esophageal and rectal temps. What is the planned usage of this field? Is the usage for the actual lowest temp measured on the patient, or just the lowest temp recorded based on a participant's chosen site?
I think the reason we did this, we had a lot of trouble in adult, especially with audits and people not knowing what temperature to look at. And as a group, the surgeon leadership felt like, let's try to make this easier, okay? Because there's a lot of different temperatures and they're recorded. There's a lot of different sites recorded. So we're giving sites the ability to say, I'm going to use my rectal temperature. That's the one I'm going to use. And I'm going to record the lowest rectal temperature consistently. If I don't have a rectal temperature, my second choice will be bladder. So look at your documentation that you have now, because you know what temperatures are documented most often and most consistently, like Chastity said, and choose. We're giving you the ability that way when it's easier for you to collect the data, and it's easier for the data to be audited. Because you give to the auditor, well, I always collect the rectal temp, or I always collect the bladder. And so it's just an easier way to, because we realize that there are lots of different methods and there are a lot of there's inaccuracies. I've seen temperatures recorded on some of these anesthesia records and you're like, wow, where did they get that from? Because there's another temperature and it's way different. So it's just giving you a little, I hate to use the word freedom, but kind of a little bit of freedom to choose which site, because you know your site best and you know what's consistently documented in your site.
Melinda, there's a question further down that says, how are the temps used? This may be asking you, like in your adult analysis, how are the temperatures used?
I can take that one.
Okay.
This is Carol. Usually, they look at the lowest temperature. It's usually a quality indicator for how cool the patient was in performing procedures. Specifically, I'm aware of aorta procedures and how cold the patient is in performing those procedures. So it's more of a quality indicator on those procedures. Also, what I don't see here that I think we collect an adult, and it may come over in the future, is time to cooling the patient down to that specific temperature that's recommended, or the time it took to cool down the patient to the lowest temperature. I don't see that here. We probably will add it in the future, but it's more of looking at how cool the patient was on bypass, and then any neurological effects from either having the patient too cool or not cool enough.
Well, yeah, because the colder the patient is, the more likely they are to fibrillate. Then they can have bleeding issues. There's lots of articles out there about maintaining the temperatures and how you don't want them too cold unless of course they're under circ arrest. But I mean, so it's really a quality, as Carol said, it's a quality metric, and there's a lot of literature out there about it, and so that's why we collect it.
That's right. Okay, question from Igor. It says, if the patient expired before the sternum closure, how would it be? Would you no open chest with planned sternal closure, or open chest without planned sternal closure?
Well, if the patient left the OR alive and their sternum is open, the answer is yes. It doesn't matter if they died before they went back for their sternal closure. The point is they left the OR with the sternum open. And so if you're filling this out at the time of your operative record, does the patient leave the OR with an open sternum? If the patient died in the OR, then the answer would be no. But I think that's a pretty rare occurrence. And so again, you're answering the question, did the patient leave the OR with an open chest?
And I just was looking, do we have in the current version, is there a complication that says there's a status post, but is there a complication related to delayed sternal closure?
The complication is you left the OR with an open sternum planned, or you left the OR with an open sternum unplanned, meaning that the surgeon left the sternum open, but he didn't plan on doing that in his overall surgical plan. Like something went wrong in the OR, which precluded him or her from closing the sternum. And so it's a different flavor.
Yeah, hold on one second. Sorry for this scrolling. Did we remove that then from the post-op?
Correct.
Yeah. Okay. So I think that
So we're just answering the question, is the sternum open?
Yeah.
When they left the OR, or if it was done at the bedside, when the case finished, was the sternum left open?
Yeah, so we removed it. So it's removed from the complication section. So the sternum left open, planned or unplanned, is removed from the post-op event section. And we just moved it up to the operative section to see if the patient left that procedure with the sternum open. We pulled over the field from adult, so it has the same verbiage, but it's no longer considered a post-operative event.
Correct. So I'm hoping that this answers these next few questions. The point is, did the patient leave the OR with their sternum open? Yes or no?
Yeah.
When will these new definitions be available? We are starting on the updated training manual as we speak. I want to get them to you as soon as possible. We have a lot of work, as you know, to do on now that the data collection form is final, that we can start working then on these definitions and getting them out. My hope would be to have them to you within 1 month prior to go live, so that you can start looking at them.
Very good. And the temperature is not, I don't believe the temperature is an operative field in congenital. What temp is used in literature? That's they're usually looking at probably the pre-op temperature or the pre-procedural temperature, or highest temperature in OR, and then the coolest temperature during bypass. You can do a Google search on temperature and procedural outcomes. How would I document if the patient had to return to OR to reopen sternum due to hemodynamic instability and left the OR with open sternum? If they return, it will be a re-op with an unplanned open sternum. So we don't have the, go ahead.
I was gonna say, it's no longer gonna be a post-op event. So you're not gonna be able to select that on the complication tab. So when if the patient left after their initial operation with their sternum closed, then you would check this box as no. When they return to the OR and the surgeon has to reopen the sternum due to the hemodynamic instability the patient is experiencing, and then they leave that OR with an open sternum, on that surgery, you're gonna select yes, that the sternum was left open. And then when they return to the OR to have the sternum closed, and you're answering the question, did the patient leave with their sternum open? The answer again is no. And so you're looking at it, every case, you're answering this question, was the sternum left open, yes or no? You're not answering whether the sternum was left open planned or unplanned. You're just answering if the sternum was left open, yes or no, following the procedures that were done by the surgeon.
Thank you. Okay.
Sometimes the chest is left open when they didn't plan on leaving it open when they started the operation. This field makes that scenario difficult. Nope, you just say the sternum was left open. You're not worried about whether the sternum was left open planned or unplanned. We completely took that away. We are just saying, was the sternum left open?
Okay.
Then why should we change the current complications open sternum planned and unplanned? Because we got rid of whether the sternum being left open, planned or unplanned. We completely got rid of those as post-op events. We're just answering yes or no. Did the patient leave the OR with their sternum open?
And I can add, I think it's because I think the word plan is hanging, they're getting hung up on the word plan.
Yes.
The real intent is, did the patient leave the OR with an open chest?
Correct.
So, and then why I would say you don't want to count this as a post-op complication, because of course, if they leave the OR with an open chest, you have to close it. So it's not like it's not a complication of the procedure. So that's why it was taken out of the complication section. It's expectation that if I leave the OR with an open chest, well, God, I've got to get it closed before I get discharged. Okay.
Which is why the delayed sternal closure procedure is a planned reoperation. Does it have a parent op type to that field? I don't know offhand. Janet, that's a great question.
This does not have a parent.
So if you did not have your sternum opened, then you just answer this as no.
Right.
Is the plan to still go live with this in the middle of the year? Are vendors going to be able to update the software? If they do not have the software updated, what is the expectations for sites to collect this data without the ability to enter it into the software?
We went over that at the beginning of the call. And if you were not on because I had the webinar locked, then you missed that information. And the timeline is under review with the surgeon leadership at STS.
Thank you, Carol.
You're
It may
welcome.
be clearer. Oh, sorry, moving on.
Okay.
It looks like we should give up some very important variables for many patients to accommodate the small number of adults.
I don't think so.
Not sure what that means.
Well, Dr. Meyer put something in the chat, which I think is important. And he said, you know, the planned versus unplanned events in our complications section was a source of innumerable questions and interpretations. And so we completely took it out of the post-op complications or events, as we refer to them as. And, you know, like he says, it was simplest to avoid the issue of planned versus unplanned and just ask the question, does the patient leave the operative setting with their chest open or not?
Yeah, and I just wanted to show something. I Igor's comment is, it looks like we should give up some very important variables for many patients to accommodate the small number of adults. And actually the reason why we added in, I don't know if you were on the call when we started the upgrade webinars, Dr. Nelson was on and she presented some data on the growing population of adults with congenital, which is great because it means that congenital patients are living into adulthood, but they still need to have some follow-up or additional procedures when they reach adulthood. So the reason why we added in the adult field is to accommodate for that growing population. I'm not sure what you mean, Igor, by saying that we should give up some very important variables. I'm happy to address it further if there's a specific question you have.
I appreciate that many fields have been removed, moved, and truncated for efficiency of data mining. However, we still have several months of data to input in this current version. Where is the incentive to enter this data if these fields will be removed in the next upgrade?
Yeah, I can take that one. So okay. Every upgrade, especially these last upgrades we did with adult and general thoracic, we've had the same feedback that why am I still entering these variables when they're just going to go away starting in a few months, or what's the importance of these and why am I taking time to do this? And the reason why we want you to continue collecting these variables is so that we have complete cohorts and that we have everybody doing the same thing for the same time frame. So entering these variables through the end of the version is extremely important so that we can still continue looking at data, understanding that it's complete. The variables go away and then you no longer have to collect them, but that's happening, with the start of this next version. So do not stop collecting any variables you see as being retired through the version change. It's extremely important that we have consistent data from all of the sites so that when we look at any outcomes or any quality metrics that we were measuring on a national level, we have all of that data still available.
In the field total post-op initial event hours, there's an incorrect spelling. Oh, Sam, thank you for pointing that out. It should be calculated, not callocated. We make up our own words now, and so no, thank you. We'll make sure that's corrected. And then the open chest left open unplanned then became a major complication of an unplanned re-op that needs to be reviewed by the quality process measures. Diane, maybe I'm misunderstanding your question, but the need to reopen a sternum is an unplanned reoperation because we don't plan to reopen it because of hemodynamic instability. But the need to go back and close that sternum once it opened is planned, so it doesn't impact the quality process measures.
Thanks, Chastity and Melinda. There's another comment here, and maybe this will help on Igor's question. This is from Dr. Meyer. It says, part of the reason for reducing the number of variables is to reduce the data collection burden. The update committee did not eliminate any fields that were thought to be important. And the upgrade committee was very thoughtful in their review. The surgeons reviewed each of these fields, the frequencies of these fields, our previous audit results, the current use of the fields, being mindful of trends and even aware of potential trends that may be important to monitor quality improvement in the future. So they were very thoughtful in this process, and also with the idea of, is this information going to be, going to be difficult for the data managers to collect? What is the burden at sites right now? For example, collecting all of the blood usage and all of the milliliters of blood given to patient, and do we need to burden all of our sites with this? The anesthesia section, the anesthesia surgeon, physicians felt that was something that they were still interested in collecting. So they asked to move those fields down into the anesthesia section for those participants. But for our general population, general sites that are not participating in anesthesia, the surgeons didn't feel the need to continue burdening sites with that, collecting that information. So it was a very mindful process, and it wasn't, oh, let's get rid of these fields because we're adding in adult fields. As you can see, we still added in fields to the congenital population for things that the surgeons felt are important or going to be important to continue in monitoring for the continued quality improvement that the database is intended for. The open chest left open unplanned. Oh, we answered that one. Okay. Any other questions?
Thank you all for your feedback and your questions. It will help as we, Melinda and I, start working on putting the training manual together, and we know what kind of clarifications are going to be needed for everyone. So thank you for that.
Yeah, thank you. Thanks, Chastity. Thanks, Melinda and team. I hope everybody has a great day.
Okay.
Bye,
Thank you.
everybody.